I'm delighted to introduce Dr. Radhika Shah. Dr. Shah went to med school at Rutgers, did her residency in internal medicine from Yale, and then finished with a fellowship in pulmonary and critical care medicine at the University of Maryland. And she's been on staff and is an assistant professor at UT-Com for the past little over 6 months, right? 7 months. And she's a consummate professional, as I've discovered her to be, and a great clinician in all areas of pulmonary and critical care and sleep medicine, actually. But she has many interests, including simulation and medical resident and medical student education. But one of her areas of interest is asthma, and she'll be talking today about deconstructing the myths of asthma. Dr. Shah?
Great. Thanks, Dr. Sethi, for the introduction. So I'll be talking today about asthma diagnosis and management. And creating a talk like this is always difficult because you sort of have a mixed audience with different levels of comfort in treating and diagnosing asthma. So the goal of the talk is really to kind of review some of the basics of asthma diagnosis and management, about things that you probably already know and kind of confirming some of that, but also introducing some tips and tricks that we use in our pulmonary clinic in terms of fine-tuning some asthma management strategies and some of the new and up-and-coming therapies that people have been using for refractory asthma. So hopefully this will be a little bit of a review for you guys, as well as learning some new and exciting things as well. All right, so the specific objectives of the talk will be to review the diagnostic strategies for asthma. We'll be reviewing some non-medical interventions for asthma control, clarifying when referral to a pulmonologist is essential, discussing associated and treatable conditions in refractory asthma, and introducing some new treatment strategies for refractory asthma. So asthma is pretty prevalent in the American population. About 7.6% of adults in the United States suffer from asthma. And out of those adults, a little less than half of those patients report having an asthma exacerbation at least once in the past year. So you can imagine the financial burden to the American economy when patients are kind of going in and out of the ER for asthma exacerbations. And you can see this data is from the CDC, but the breakdown of the asthma prevalence based on age, sex, and ethnicity. So we'll kind of go through this presentation through a case presentation and hopefully break down some myths and beliefs that providers have regarding asthma diagnosis and management. You may or may not have those beliefs, but we'll go through. It's a good way to structure a talk, basically. So we'll talk about a 23-year-old woman who presents to your clinic with intermittent shortness of breath and wheezing. She has seasonal allergies. Cold air and dust seem to trigger her episodes. She gets pulmonary function tests and they come back normal. True or false? She does not have asthma. So this is one myth that we'll try to dispel today. So normal pulmonary function tests rule out asthma, and so that's not true, and we'll talk a little bit about that. So diagnostic criteria, some of this stuff, a lot of this stuff that I talk about is structured around the GINA guidelines, which is, it stands for Global Initiative for Asthma, and it's a group that comes up with the guidelines and recommendations for a lot of asthma diagnostic strategies and treatment strategies. So the diagnostic criteria for figuring out whether somebody has asthma or not is symptoms of wheezing, chest tightness, and cough of variable nature, plus a variable airflow obstruction. And the thing that I want to emphasize for this is the variable nature of symptoms. So, I mean, otherwise you can say, why isn't this COPD or emphysema? For asthma, it's the variable quality of symptoms that is the key. So oftentimes, the first test that you want to do if you have a patient you're suspecting of asthma is spirometry. And I like to, when I send patients for spirometry, I like to tell them what they're expecting. So for a lot of the residents, I don't know if you've ever been to the pulmonary function lab. You should definitely go visit them. They're on the first floor of the medical mall. But it's always good to tell a patient what to expect when they're getting pulmonary function tests. So you tell them you're going to breathe in through a long tube. You're going to have a respiratory therapist basically yelling at you to try to get do the best that you can on your pulmonary function tests, and they're gonna come up with some numbers. The other part that is not totally necessary for asthma diagnosis, but lung volumes are done in something that looks like a telephone booth when you do body plethysmography. So you want to kind of give them a heads up about that too, because you have patients who are claustrophobic and things like that. So I do like to counsel patients on what to expect with pulmonary function tests when they go do them, and the fact that it's non-invasive, which is very important to tell them as well. All right, so as a pulmonologist, I wish that all my asthma patients had PFTs like this. And so some of your patients will have it, but unfortunately, diagnosing asthma sometimes is a little bit more trickier than this. But I'll start off with this sort of classic pulmonary function test, and then we'll kind of go on to how to figure out if someone has normal pulmonary function tests, whether they have asthma or not. So we'll start off with looking at the flow volume loops, which are at the bottom of the slide. And if you look at the red line on the flow volume loop, you'll see that on the expiratory limb that there is scoopiness of the expiratory limb, which indicates that there's obstruction, airway obstruction. The green line is after bronchodilator has been administered, and you'll see that some of that scoopiness has gone away. So just based on flow volume loop, and I encourage people who look at PFTs to always start off with looking at the flow volume loop, that this patient has some reversibility of their obstruction. So let's look at the numbers and see if that's verified with the numbers. So this patient, actual FEV1 over FVC is 68, which is lower than the lower limit of normal, which is 75. Now, I'm not going to talk about GOLD criteria versus ATS criteria in this presentation for diagnosing obstruction, but if you use GOLD criteria, which means that your cutoff is 70 for obstruction, this is 68% FEV1 over FVC, which still indicates that this patient's obstructed. If you look after bronchodilator administration, you'll see that the FEV1 over FVC has improved to 77, which is above the lower limit of normal and also above 70, depending on which criteria you use, which shows that the obstruction has reversed after bronchodilator. And then if you look at the percent change in the FEV1 as well as the FVC, you'll see that it's greater than 12%, which indicates reversibility, which indicates a significant bronchodilator response. So in summary for this pulmonary function test, which is a classic PFT for an asthmatic patient, you see reversible airway obstruction with a significant bronchodilator response. Now, again, I wish all of my asthma patients had PFTs like this, but that's not the case, and this is real life. So, well, this is usually what you're going to see with a patient who has asthma, and that's a normal pulmonary function test. So what do you do now? How do you figure out whether your patient has asthma or not? So this is the general algorithm that most of us use for diagnosing patients with asthma. So if you have a patient who has symptoms that are consistent with asthma, the first thing to do is obtain spirometry. If you see that you do have a obstruction with a significant bronchodilator response, then you can say that you've got asthma and treat them accordingly. But what if you have normal pulmonary function tests and you go down this pathway? So you have a couple of options. You can repeat spirometry when a patient's more symptomatic, or you can go towards a methacholine challenge. Now, I'll talk a little bit about empiric treatment for asthma, but let's, for now, assume that those are your two options. So we'll talk a little bit about methacholine challenge. So the more general term for methacholine challenge is bronchoprovocation challenge testing. So methacholine is the most commonly used drug or nebulized treatment for bronchoprovocation challenge testing. So for most of the time, you're going to be using that. But there are a couple of other interesting kind of maneuvers that some pulmonary function labs can do to help provoke an asthma sort of picture in your pulmonary function test so that you can diagnose somebody with asthma. So I've seen some pulmonary function labs do exercise in their lab to try to induce an obstructive physiology on their pulmonary function test. So you have a patient do spirometry, have them run around wherever, and then come back and do another spirometry. That way you can kind of simulate their symptoms and their airway obstruction on spirometry. Something that comes up on our It comes up on our pulmonary boards a lot. I've never actually seen it in real life. It's called eucapnic voluntary hyperpnea, which is another way to kind of simulate exercise-induced asthma, where you have a patient breathe in deeply and quickly to a certain goal minute ventilation and do spirometry before and after the maneuver, and that's supposed to simulate also exercise-induced asthma. Hypertonic saline and mannitol can also be used as sort of bronchoprovocation challenge testing as well. Now, all of these things are sort of not as widely used as obviously methacholine, and I'll talk a little bit more now about methacholine challenge testing and how we do it in the pulmonary function lab. So methacholine challenge testing is what you have patients do is they come in and they do their baseline spirometry, and they get increasing concentrations of methacholine administered to them in a nebulized solution, and they continue to do spirometry after each. And what you're looking for is a 20% reduction in their FEV1 after administration of a certain dose of methacholine. The sort of thinking and theory behind methacholine is that everyone at some high concentration of methacholine is going to have bronchospasm. That's the theory behind it. So what the pulmonary function lab does is does it based on a protocolized increase in concentration, and they stop at a certain high dose if you have or haven't had a bronchospasm. And when you read so they either stop when you've had a 20% reduction, or they stop at that max dose of their protocol. And depending on where you've had your decrease in FEV1, this is the chart from ATS guidelines, but you can determine whether or not there's some airway hyperresponsiveness. So if you see at this high concentration of methacholine, if you have bronchospasm at this concentration, it's still considered normal. So like I said, at certain high concentrations, the theory is that methacholine can cause bronchospasm in anybody. And what you're looking for is bronchospasm in people who are getting lower doses of methacholine, and if they're therefore hyperresponsive. So that's how we read a methacholine challenge that's done in the PFT lab. So methacholine challenge, there's some contraindications to doing it. If you have a low FEV1, patients who you're concerned are going to have a real asthma exacerbation from doing the test, you're not going to do it. But, I'm going to talk a little bit throughout the presentation, and you'll hear about, I'm new to Chattanooga, so I've learned that, in the Southeast, there's a real issue with access to care. And I think that, it's all great and good to bring patients back for repeat spirometry and methacholine challenge and all of that stuff, but really getting patients to just get treatment for their suspected asthma is sometimes kind of your goal. So I think that most of the pulmonologists would agree that if you have someone who you're suspecting of asthma, you should get one pulmonary function test to make sure you're not dealing with some other alternative diagnosis and completely go down the wrong path. But I do think that it's not wrong to treat patients with a short-acting bronchodilator to test them out if they do have normal pulmonary function tests to see if they do have improvement in their symptoms, especially if you can't keep bringing them back for repeat spirometry and methacholine challenge. So I do think that it's not wrong to just try a bronchodilator and see if they feel better. Okay, so let's go back to our case. So you determine that your patient has asthma based on clinical symptoms and would like to start treating empirically. True or false? You need to send her to a pulmonologist. So now I know Dr. Sethi is going to kill me for saying this, but I'm going to say that patients with asthma if they have to see a pulmonologist, I think that is a myth. I think that, I've seen a lot of patients, and obviously we are happy to see patients at any stage of diagnosis for asthma, but I do think that, again, because of our issues with access to care, that you can start treatment for patients in the primary care clinic easily for asthma. And so I'll talk a little bit about our initial treatment strategies and what you can start off with in the primary care setting. So we talked about diagnosis. Let's talk about treatment a little bit. So I'm not going to go through this in excruciating detail, but generally, when we're starting to decide on treatment for asthma, we want to start talking about classifying your asthmatic patients based on their asthma severity. And the asthma severity is determined, and this will come up on internal medicine boards, by the way, guys, but you want to figure out how severe a patient's asthma is before deciding treatment. So this is kind of determined by daytime symptoms, nighttime symptoms, how often a patient's using their short-acting bronchodilator during the day, if it's impeding on their normal daily activities, like they're staying home from work or from school, their lung function on pulmonary function tests, and whether or not they're having a lot of exacerbations that are requiring prednisone. So depending on your asthma severity, it's going to help determine how, what step of treatment you're going to start a patient on. And so this is where your step-up therapy comes in. So the whole theory behind treating asthma is that you are going to put patients on a step-up or step-down a therapy regimen. And what that means is that when you start a patient off on a treatment, instead of, if it's not controlling their symptoms, instead of taking something away and trying something new, you're going to increase their therapy and not take anything away. So that's what step up means in terms of step up or step down therapy. So depending on your severity of asthma, you start them off on a particular step. And if they're well controlled, you leave them on it. If they're not well controlled, you step up therapy. The general strategy is to when having patients on controlling inhalers, is to start off with an inhaled corticosteroid. That's the general strategy for management for asthma. And then as you go through the steps, at any point you can add on a leukotriene inhibitor, so montelukast, or you can continue to increase your inhaled corticosteroids, add a long-acting beta agonist, and eventually start considering things like omalizumab and chronic steroids. And we'll talk a little bit more about getting into the step 5 and step 6 therapies for asthma. That I don't expect people to do in primary care setting, but at least starting patients off on their inhaled corticosteroid is totally reasonable. So I like to talk sometimes about sort of where our therapy and where our teachings come from usually. And this is something that came out of the 90s in terms of why we start with an inhaled corticosteroid. And this is one of the first studies, but there were more afterwards. But why do we do an inhaled corticosteroid? Part of it is the pathophysiology. If you think about asthma, it's airway inflammation, eosinophilic airway inflammation, and smooth muscle constriction. It's a combination of those two things. And there's a lot of allergy component to asthma. So this study, which was a comparison of beta-2 agonist terbutaline in comparison with an inhaled corticosteroid in newly detected asthma patients. So they took about like 100 or so patients, divided them into two groups, into the beta agonist group versus the inhaled corticosteroid group, patients who were newly diagnosed with asthma, and compared their subjective symptoms and peak expiratory flow. And they found that there was a significant improvement in the inhaled corticosteroid group compared to the beta-2 agonist group. So this is sort of where some of that step-up therapy and why the initial therapy for inhaled corticosteroids came about. And then there's been multiple studies after that, but that's sort of where it comes out from. So, you know, step-up therapy really depends on whether you decide that a patient has good asthma control. And how do you decide that? You know, we all have those patients who, they have to use their albuterol inhaler once a month, and they're like, oh my gosh, my asthma is so uncontrolled. And then you have your other patients who are using their asthma inhaler 6-7 times a day, and they're like, doc, I feel great. It's fine. That's not a problem at all. So how do you figure out where, some of that matters, right? A patient and their perspective on their disease, but how do you more objectively figure out whether a patient is well controlled on their asthma or not? And so something we use in our clinic frequently is the asthma control test. So this scoring system is kind of based on how much a patient is having symptoms during the day, whether they're waking up at night, needing to use a medication, how much it's affecting their day-to-day routine, and you score it up and you see if a patient has a score less than 19 that they're considered to be uncontrolled. So this is a tool you can kind of use if you feel like you're not sure whether you need to step up therapy or not for a patient. It's just another kind of additional data you can use in your in your clinical management. Okay, so when do you absolutely have to refer to a pulmonologist when you have a patient who has asthma? So I think that if you're having trouble with diagnosing, I think it's totally reasonable to send to pulmonary. And so that's before bronchoprovocation testing. I would say go ahead and send a patient to pulmonary for referral. Abnormal imaging is something that can confound your diagnosis. So if you look at the CT scan that's on the slide, there's some central bronchiectasis. If this patient has PFTs that look like asthma, their diagnostic strategy and treatment management is going to be completely different because this patient actually looks like they have allergic bronchopulmonary aspergillosis. So that's going to be a completely different treatment pathway than just regular old asthma. So I think that that's part of the reason why abnormal imaging really does need to go to a pulmonologist. Presence of restrictive lung disease is also going to buy you a pulmonary referral because your diagnosis may not be asthma. It might be something like pulmonary fibrosis, something like that. If you're having trouble controlling, getting the patient to optimal therapy, obviously, and if you have a patient that you're considering sending to an allergist, now a lot of these allergy clinics do have a pulmonologist there, but I would suggest that also that they need pulmonary referral for that as well. Okay, so let's go back to our case. So you've placed your patient on an inhaled corticosteroid and a long-acting beta agonist, and she has not improved. She continues to use her inhaler 2 to 3 times a day and has missed work once in the last week. So what do you do now? You add more inhalers, you increase their inhaled corticosteroids, what are you going to do? So this is another myth that I'll hopefully help you guys with, is that asthma can only be treated with inhalers. So that is false. So there is a whole multimodal approach to managing patients with asthma, and that includes assessing their environment, assessing comorbidities that could be worsening their asthma symptoms, and I think all of those things need to be assessed. So let's talk first about occupation. So if you hang out with us, you'll see that when you talk to patients with lung diseases, that you do need to ask about their occupational exposures. I think patients spend 8 to 10 hours a day at their job, and their environment could be contributing to their symptoms. So in occupational medicine, there are 2 ways that you can divide patients who have asthma symptoms that might be related to work. It's a technical difference, but it does matter especially when patients are trying to figure out whether their work is causing their symptoms. So there's work-related asthma and there's work-exacerbated asthma. Work-related asthma is asthma that is caused by your work exposure. Okay, so you're completely asymptomatic when you're away from work, from vacations, weekends, things like that. Work-exacerbated asthma is when patients have pre-existing asthma and their symptoms are exacerbated by whatever work exposure they have. So those are sort of the 2 differences. There's also you can further differentiate occupational asthma by what the exposure is. So there's sensitizer induced asthma and there's irritant-induced asthma, but I won't go through kind of the details of that. It's a little outside the scope, but what I did want to talk about was some of the exposures that are common to cause asthma at the workplace. So a lot of these are kind of common sense. So if you work with animals and things like that and have some sort of animal allergy, that's obviously going to increase your symptoms at your workplace. There are 2 things that I wanted to point out on this chart. So something that's been more popularized in the occupational medicine literature is diisocyanates, and something to kind of keep in mind. So painters and people who work with polyurethane, it's been circulating in the literature a little bit more that this is a big cause of occupational asthma. And the other thing is, whenever you practice, especially in training, you're moving around a lot and practicing in different places. So you start to figure out when you're in clinic where people work, where the big employment areas are. So I'm still trying to figure that out in Chattanooga. But in Baltimore, we had this huge Bethlehem Steel, which was a huge employer in the past, and we also had a shipyard over there, so that we had a lot of patients who had asbestos exposure. So that was sort of the thing that you start to look out for. So here I've had 2 patients, not asthma patients, who are carpet mill workers from Dalton. Now I don't know if that's like a huge employer, but it was just some interesting that carpet makers actually, due to the guar gum that they use for the carpet making, can cause asthma. So a few finds when you're taking your occupational history that patients are working in the carpet mill, that might be an issue for asthma. So, obviously we're all time constrained, and the proper way that they talk about in the textbook about taking an occupational history is to go through every single occupation that a patient's had to figure out if they had some sort of pulmonary exposures. I suggest that a good screening question, so that you're not taking 30 minutes of your clinic trying to figure this out, is to ask a patient if they've had any dusty or dirty jobs in the past or currently. Is sort of how I kind of use as a screening question to figure out if their occupational exposures are causing their symptoms. And I also ask them if they think their work is contributing to their symptoms, because they're going to know the best. Oh yeah, I feel worse when I'm at work. My breathing is worse when I'm at work. So I think that those are 2 good screening questions if you're trying to figure out if their job is causing their symptoms. Okay, the other thing I like to assess is their home environments. So how could you not have asthma if you lived in a place like this? Like, there's just no way. So I like to talk, so this part of the talk, I'm going to be frank, is not evidence-based. So if you look at the GINA guidelines, and they talk about assessing home environment and recommending modifications to the home to improve asthma symptoms, they actually recommend against it based on whether or not it's cost prohibitive and the fact that it doesn't have great evidence. And I would argue that anecdotally, I've had success with patients when I do ask them to modify something in their home environment in terms of their asthma symptoms. That was a huge part of a lot of my mentors' asthma management in fellowship. And take this as you will, but I think that this part of the talk is actually really important in terms of patients who have asthma and their asthma control. So we'll talk a little bit about the home environment. All right, the first thing I like to counsel patients on is carpeting in their house. So carpeting theoretically, and if you go to a carpet store, I've learned, they tell you that this is not an issue, but I think that sometimes it is, especially if you have old carpets, that they can hold allergens, especially if you have pets and things at home. I encourage patients, and obviously this is a part where it could be cost prohibitive to have patients change this in their home. But if there's a choice, I would say that carpeting is a no-no in a patient who has bad asthma. If you do have to have carpet, to try to keep it clean. The other thing to kind of ask about is visible mold in the house, and this can certainly worsen asthma symptoms. And kind of getting that taken care of is something that you want to assess in patients who have difficult to control asthma. Okay, so this is a big issue, and this definitely can make a difference in asthma symptoms, especially if you have patients who have pets who they have had allergy testing that has confirmed that they are allergic to Fluffy the cat or whoever. I've had patients who have their cat sleeping on their face basically at night, and they're like, I don't understand why my asthma is not well controlled, So I think that assessing if they have pets in the house, are they actually allergic to their pets, and counseling them on maybe Fluffy needs a new home, or maybe I think that that's something that needs to be assessed in patients who are having issues with their asthma symptoms. A compromise, this obviously you can imagine is very difficult to convince patients of. A good compromise is to ask them to not have Fluffy sleep in the bedroom, so that and kind of keep that bedroom pet-free, so that there's maybe some more limited exposure to your allergen. If the patient smokes, or if they have family who smokes in the home, that can be a trigger for asthma symptoms, and that's something you need to assess. And then wood-burning stoves is also sort of in the, I've never actually seen this in real life, but it supposedly can worsen your asthma symptoms. And the other thing I recommend in patients who may have dust or dust mite allergies is to, in general, keep the house clean. But for their bedroom, I do recommend that they get hypoallergenic covers for their pillows and for their mattresses, and to not use, 20-year-old pillows, basically. It helps create a barrier in terms of dust between the patient and the dust mites that kind of get into your mattress. I actually had a patient once who was 40 years old. She came in with like new wheezing at night and improved with bronchodilators. And she eventually figured out that she was feeling better when she slept in the guest room. And we figured out that her husband had this old pillow that he slept with that was from his childhood, and they got rid of it, and then she was completely asymptomatic. So I think that it's worth investigating, because this patient then didn't need inhalers ever. So. Okay, and the last thing that I want to mention in terms of difficult to control asthma and kind of going past inhalers is assessing comorbidities in asthma. And so there are a lot of things that are very closely and complicated, have complicated relationships with asthma. Allergic rhinitis, obstructive sleep apnea, vocal cord dysfunction, reflux, anxiety, and obesity have all very complicated interactions with asthma. I won't talk about all of them, but I'm going to touch on a few of them that could be potentially modifiable in terms of helping patients with their asthma symptoms. So allergic rhinitis and allergy management, I think, is a huge component of treating patients with asthma. So that part of that is adding the Singulair that's in a lot of the steps in the step-up therapy. Including any sort of antihistamine generally will help with allergic rhinitis and asthma symptoms. So I'll use stuff like cetirizine tends to work well for that type of thing, or anything that really the patient likes. And then sending to an allergist for immunotherapy and actually doing skin testing can be helpful in figuring out what is that patient's trigger, especially if they don't know themselves, for treating their allergies. Okay. GERD. GERD has a very complicated relationship with asthma as well. When studied with pH testing in patients with asthma, in difficult to control asthma, they found up to 60 to 70% of patients have reflux in difficult to control asthma. So that's something that you need to kind of assess and think about, whether their reflux symptoms are well controlled or not, and may be worsening or causing their asthma symptoms. There's two mechanisms that they talk about that are potentially maybe related to asthma. One of them is direct acid aspiration of causing bronchospasm and inflammation. And the other is reflux, where when acid basically reaches the lower esophagus and the lower esophageal sphincter, that there's some reflux that causes, in turn, bronchospasm. So those are the two proposed mechanisms for why reflux may be associated with asthma, and something to assess when we're having difficulty with control with asthma. And I always ask about this, especially on the first visit for asthma. Okay, obesity and asthma. So in Europe, they have all these really cool multidisciplinary asthma clinics where they do a lot of nutritional and weight loss counseling in patients with difficult to control asthma. The mechanism as to why obesity worsens asthma or worsens symptoms of asthma is sort of multifactorial and not well understood, but a couple things are sort of common sense. So, patients who are obese tend to have a restrictive physiology on their pulmonary function test due to their chest wall tissue, and that can cause a sensation of worsening shortness of breath. There's some theories that the hormonal differences in obesity can contribute to the inflammatory changes in the airways involving leptin and things like that. So that's another theory behind why obesity can worsen your asthma symptoms. And then lastly, and this is a little bit more complicated, but it's kind of well known that obese patients breathe at a lower functional residual capacity, which means that if you look at this chart, that they have a lower expiratory reserve volume. So the theory is that they have less reserve, and so they have they have the sensation or shortness of breath because of that. Again, these are all theories, but there is definitely an association between obesity and asthma. Why that is multifactorial at this point. Okay, so vocal cord dysfunction. So vocal cord dysfunction has sort of a complicated relationship with asthma. It can be associated with it, but it can also be confused for asthma. So it's something to think about when you have a patient who's having trouble with asthma symptoms. And this is definitely a board question at some point, whether it's internal medicine or pulmonary, I'm not sure, but this is like a typical board question where you have a patient who you think has asthma, comes into the ER, and they're wheezing and they're short of breath, and you keep giving them nebulizers, not getting better, and they get themselves intubated, and then all of a sudden there's no wheezing, they have no obstructive physiology on their ventilator, and they're totally fine. So that's like their classic question of vocal cord dysfunction. So what happens in vocal cord dysfunction is that during normal mid-inspiration, you have opening of the vocal cords. In vocal cord dysfunction, you have abnormal closure of them, causing the stridorous wheezing sounds that you might hear in a patient with vocal cord dysfunction. How that will look on pulmonary function tests that's different than asthma is that you'll see a flow limitation or flattening of the inspiratory limb on pulmonary function tests, and that can give you a clue that you might be dealing with vocal cord issues. Okay, and then the last myth that I'll talk about in terms of asthma diagnosis and management is about chronic steroids and the fact that patients' symptoms cannot be relieved with inhalers, allergy control, and comorbid condition. Looking at comorbid conditions, the only option is chronic steroids, and I will argue that that is not the case. We might end up on chronic steroids eventually, but I think there are other treatment options in between that you can try. So this is where we get to kind of some of the neat stuff that's going on. So anti-IgE therapy. So this is talking about omalizumab, or brand name Xolair. So this is basically in the asthma pathophysiology. Plasma cells during an allergen sort of exposure, plasma cells release IgE, which then causes mast cell activation for release of cytokines that then cause eosinophil migration into the airways. So omalizumab blocks IgE and theoretically then reduces asthma exacerbations, allergic inflammation, and symptoms. So the indications for omalizumab are moderate to severe persistent asthma with an elevated IgE level, or positive skin testing, and incomplete control with inhaled corticosteroids. Omalizumab is administered subcutaneously every 2 to 4 weeks. So this is some of the original evidence behind it, and there's been a few more studies. I think this was in 2010, where they took patients who were on an inhaled corticosteroid for moderate to severe persistent asthma and divided them up into a omalizumab arm and a placebo arm, and they compared primary endpoint of asthma exacerbations and secondary endpoints of quality of life and bronchodilator use, and they found significant improvements in all of those parameters when using omalizumab compared to placebo. Then after omalizumab came anti-IL-5 therapy. So this includes 3 drugs, mepolizumab, reslizumab, and benralizumab. So IL-5 is a cytokine responsible for eosinophil migration, and that's what these drugs block. So the indications for anti-IL-5 therapy are pretty similar to omalizumab, except for an elevated eosinophil count is actually included in that as well. They're also given sub-Q, except for reslizumab is given as an IV infusion. So one question is, how do you decide what to use if the indications are kind of similar between both, or there's a lot of like crossover in terms of indications between these 2 drugs? I think that's still being debated in the literature, and there have been some studies comparing mepolizumab with omalizumab, and there tends to be kind of similar efficacy in both, or they'll talk about it one or the other being non-inferior, and that's sort of where the literature is at right now. The advantage of using benralizumab is that you can, it's a little bit less frequently administered than the other drugs, so it can be administered every 8 weeks rather than the 2 to 4 weeks of the other drugs. So that's the advantage of that. Okay, and then the last therapy for refractory asthma that I wanted to talk about was bronchial thermoplasty, which is a really cool procedure. Evidence is not robust for it, but it can be used for patients who are really, can't get off those chronic steroids for their asthma. So basically the technique for bronchial thermoplasty, it's a really fun procedure, but basically you do a bronchoscopy, and you have a catheter that uses heat therapy to against the smooth muscles in the bronchial walls. And the theory is that you have less smooth muscle constriction when you use heat therapy for this procedure. So the way the procedure is done is in 3 stages. The first procedure, you do it you do a particular lobe in each procedure. So the first procedure, you do the right lower lobe. The second procedure, you do the left lower lobe. And then the third procedure, you do the bilateral upper lobes. And you do them 2 weeks apart. And you try to get that catheter to touch as much of the airway walls that you can see as possible so that you have the least amount of bronchoconstriction later on. I think the biggest risk of this procedure is that in the short term, like right the day of or the day after the procedure, you could induce an asthma exacerbation. But the theory is that the long term that you're going to have less. And this is the kind of the main trial that launched bronchial thermoplasty, where they had 288 patients who had uncontrolled severe asthma on an inhaled corticosteroid and a long-acting bronchodilator, beta agonist, and divided them up into a bronchial thermoplasty group and a sham bronchoscopy group. So they basically just made them think that they're getting a bronchoscopy, but they did not get bronchial thermoplasty. And they compared primary endpoint of quality of life and secondary endpoints of ER visits, days missed from work. So you can imagine this is not the most robust primary endpoint for bronchial thermoplasty, but this is the trial that sort of launched it as a potential therapy for refractory asthma. So something to consider. We don't have the catheter here, but it's something to consider for referral for refractory asthma. And then some of the up-and-coming therapy, I'm not going to talk about this, but they are looking at roflumilast for asthma. It's currently used for COPD, for refractory COPD, but they are studying it for asthma indication. And then other interleukins, so IL-4, 17, 13, and 9 are currently also are in clinical trials for the indication for asthma. So the last thing I wanted to talk about in terms of refractory asthma and what to do about it is barriers to care and noncompliance. And some of these things, I think if you don't work with inhalers a lot, you're not going to totally understand that this can be a barrier to care. So one of the things that we always try to have for patients who have bad asthma is to have an asthma action plan. And that is important in terms of having patients take control of their care and to be aware of when they're having a bad day and what to do about it. So basically what we do is we teach them how to do a peak flow. And our PFT lab can do that too. If you have a patient who you need inhaler education or peak flow education, you can send them to our PFT lab and they'll do that. But basically you tell them, if they're having a bad day or they're starting to have worse symptoms or lower peak flows, what medications they need to use for rescue and when they need to call a doctor or come to the ER. So that's, I think, really important to prevent back and forth ER visits for these patients. The other thing I wanted to talk about was inhaler adherence. So there's a surprisingly large amount of patients who don't know how to use their inhaler and use it wrong. And you're never going to know unless you're there living with them and watching them use their inhaler. So this was actually a study in COPD where they used objective they used some audio device on their inhalers, and were able to detect whether or not a patient was using their inhaler properly or not. And they had a 30 to 40% error rate for patients who were using their inhalers for COPD. And this is sort of the breakdown of the types of errors that the patients had. So not inhaling strongly enough or deeply enough was one of them. I think some of the funnier ones was like exhaling into the mouthpiece, so that doesn't make any sense. So that's definitely not going to work if your asthma patient's doing that. Inhaling too many times, so you're not going to get medication, is another error that was happening. So that's an issue. So before you say a patient's having difficult to control asthma, you want to make sure, are they using their inhaler correctly, or are they exhaling into their albuterol inhaler, So these are all of the ways that you can administer inhaled medication currently. And I can tell you that if I picked somebody out of the audience and told them to please show this patient how to use a Respimat, you wouldn't be able to do that. There's so many different delivery devices out there, and each medication is different. Like HandiHaler is how Spiriva is administered, but you can also do a Respimat too. So patients can get really confused. One of our nurse practitioners yesterday said that a patient was swallowing their Spiriva capsule instead of putting it into their HandiHaler. So that's not going to work either. So I think that, before you say, my patient's non-compliant, my patient's not getting better, you need to assess whether their inhalers are actually, they're using their inhalers properly. So as in everything in life, there's an app for that. Now, obviously, if you have a patient who doesn't understand their inhaler, they might not be app savvy on their iPhone, but you can. There are apps where they actually show, you can pick I have a patient who's on a FlexHaler, and it'll show you step by step how to use the inhaler. So you can just search inhaler under your app store, and there's like multiple apps for that. So, and you can also have it on your phone and show them in the clinic, like this is how you use your inhaler. So something to consider. And then the last thing I wanted to kind of emphasize, especially to people who don't maybe prescribe inhalers a lot, is inhaler cost. So coverage for inhalers is really difficult. You have a lot of patients who have insurances that don't cover any inhalers. Albuterol inhaler, just a rescue inhaler, can cost up to $50 a month, and that's only just one inhaler. So if you go through more than one, that's more. And any controller medications such as inhaled corticosteroids or long-acting beta agonists can be hundreds of dollars. So a couple of examples. So if you look at the, when I was a resident, I would often refer patients to the Walmart $4 plan to look for an antihypertensive that they could potentially afford. If you look at the Walmart $4 plan, there's only ipratropium nebulizer in there for asthma. There's no inhaled corticosteroid. If you search asthma, there's nothing else in the $4 plan. If you ask a patient who's uninsured to use those good RX coupons, this is how much an Advair discus costs using one of those coupons. So $400 for one Advair discus. And then, so I was just searching inhaled corticosteroids on Google and how much they cost for this presentation. And actually, a lot of people apparently ask, what is the least expensive steroid inhaler? So if you wanted to know, it's beclomethasone, or QVAR, and it's $177 a month. And anecdotally, I don't actually think it's a very good inhaled corticosteroid either. So that is where we're at in terms of inhalers. So oftentimes, for insurance companies, there may be one that is covered, and you kind of have to figure out what that is, or you have to try something first before you go to another inhaler, so it can become very complicated. So I think, again, before deciding that your patient is non-compliant and that your patient is not well controlled on the asthma medications, I think you do need to think about can they just not afford the medication, okay? So some things that you can do, so some of the inhalers do have drug programs if your patient's truly indigent, where they can submit an application and get a year's supply of free inhalers through their drug program. But I have to admit, it's very difficult in our clinics and trying to get patients squared away with their inhalers. Okay, so that's my talk. So hopefully I got was able to relay to you guys that that objective evidence for asthma is always preferred, but you can empirically treat if asthma is strongly suspected after getting at least one pulmonary function test. You can always start the process of diagnosis and treatment of asthma as a primary care provider. Know when to seek expert opinion, and that there's lots of therapies that you can try if indicated to prevent people from being on steroids forever. So it's always something to think about. Thanks. Any questions?
Excellent job. That was very enjoyable. What is the longest follow-up you have after bronchial thermoplasty in terms of what happens to airway dynamics in the long term if patients have been treated with thermoplasty?
So I think that in literature, probably the longest follow-up they have is 4 to 5 years. From personal experience or from my mentor's experience, it's about 2 years for airway dynamics. And I would say anecdotally in those clinics, there has been stabilization of airway dynamics, like initial improvement and then stabilization. But in terms of the literature, I'm not sure about that.
One comment on the inhaled steroid cost. What we do is we actually give the entire list of all the alternatives, a printed page to the patient, and have them find the least expensive one. Even then, it's like $42, which a lot of people can't afford. And the sad thing is that some of my patients go to this place in the pharmacy in Canada and get their inhalers, and a lot of them are from India, for example. An Advair costs $3 or $4, and Spiriva costs about the same. And the markup for our patients is just unbelievable.
Yeah, I agree.
The effect of thermoplasty, are you sure that it's on the smooth muscle only, or is there transferred energy to the vagal nerves that accompany the large airways?
I think there is a theoretical effect on the vagal nerve on there, but I think the main physiologic mechanism that they propose for the bronchial thermoplasty is the smooth muscle constriction. But I think it's theoretical that there is some vagal nerve.
Actually, destruction, failure to regenerate. All the other tissues regenerate, but the airway smooth muscle does not.
Right.
But I think that patient selection is very important in that. If you did, there are studies looking at optical tomography to select patients who have very hypertrophy airway smooth muscles. Those patients tend to have a better response.
Yeah.
Periods of years of contraction, airway smooth muscle those patients.
I had one other comment about the GERD.
Yeah.
It's a complicated issue.
It's complicated, yeah.
There was a 2009 New England Journal paper, which we participated in when I was in Florida, that showed no benefit to proton pump inhibitors in people and patients. They had like 400 patients with asthma, and there was no benefit. So it's a complicated issue. It may not be acid. It may or may not be related. There is in COPD, there's probably a pretty clear. We published something in Chest that looked at COPD exacerbations in people with GERD. Asthma, it's not clear. There is this reflex in kids. It may not be
There's a
in
lot of
adults.
literature in pediatrics, yeah.
It may not be in adults. It's a complicated issue. As a general rule, if somebody's got symptomatic heartburn, a proton pump inhibitor is not out of the question.
Yeah.
Some will classify refractory asthma as COPD, and if that is the case, do you treat it as COPD?
I think that sort of gets to the question of